Thank you to the organising committee for asking me to speak today. So I'm a thoracic radiologist and I principally work on lung cancer imaging. And today, the first talk of this session, it's going to be a relatively basic talk, really looking at how we follow up patients who've had lung cancer surgery. And about 20 to 30% of patients who present with lung cancer have disease that's actually curative. And the ideal curative treatment is surgery with removal of the tumour. And what I'd like to talk about during the session today is, first of all, just to define the different types of surgical operations that patients have. And then I'm going to talk about some complications, and those are complications that I think are interesting to radiologists and the ones that we're good at picking up. And finally then, for the second section of the talk, to talk about recurrence and how we assess for recurrence post-lung cancer surgery. So at our MDT, when a patient presents with lung cancer, the first thing we're trying to establish is if the patient can have curative treatment. So if we exclude that the patient has metastatic disease and they have nodal disease that may be not suitable for curative treatment, patients are then defined suitable for surgery. And surgery is really treated as the mainstay of treatment if patients are medically operable, that they have good functional reserve in their lungs. And when we have a patient we think is suitable, we have to define what type of operation they can have. And that really depends on how invasive the tumour is and what structures it invades, and in particular, how it invades the central airways. So lobectomy was defined in about 1995 by the Lung Cancer Study Trial as the definitive treatment for parenchymal lung tumours, so tumours that don't involve the main airway. And it involves removal of the lung, or removal of the lobe with transection of the lobar airway and the pulmonary and the associated pulmonary artery. In our institution, all patients also have a lymph node dissection where the nodes within a defined territory are removed. And this is different from systemic sampling where the nodes are simply sampled. And we think that you get more definitive information about the nodes if you remove them, but there also may be some survival benefit in patients who present with more advanced stage disease. So when you're looking at patients who've had a lobectomy, on day one, you'll usually have a chest drain in situ. You'll have a variable amount of changes on the side the lung has been operated, and the changes can be quite significant. By day 3, if the patient is doing well, the drain will usually come out and they'll start to see some volume loss. And the amount of volume loss is quite variable. This patient at a month is starting to see some volume loss, and by a year it's more defined and is usually stable after a year. For those who are still awake after lunch, this patient unfortunately though developed a small metastasis in a rib here. So careful attention on follow-up is very important. But we don't follow patients up in our hospital with chest x-rays. All patients who've had lung cancer resections are followed up with CT. And not only can we identify the volume loss and other things a chest radiograph can do, but we can actually see the area that's been operated. So we get a good definition of the bronchial stump, which can have a variable amount of soft tissue thickening around it, depending on what type of operation and what lobectomy they've had done. Pleural thickening is certainly not uncommon, particularly if patients have had chest wall resection at the time of surgery. And these are areas that are commonly overcalled as disease progression, and they're almost a normal finding when we're following these patients up. Sublobar resection is used for smaller tumours in patients who are unsuitable for lobectomy. And these are, as I said, so usually in minimally invasive adenocarcinomas, and it involves removal of just a segment of the lung. So the segmental airway and pulmonary artery are removed. Interestingly, when you follow these patients up on CT, they often actually have more pronounced changes because you have a suture line that extends back to the hilum, and they can often have quite significant soft tissue thickening along that suture line, which again is almost a normal finding in these patients. We don't do wedge resection in our hospital for any patients with primary lung cancer. We exclusively use this for metacystectomies. So sleeve lobectomy is used for more central tumours, so tumours that start to involve the main airway. And the reason a sleeve is done is to try and avoid doing a pneumonectomy in these patients so that they'll get a long-term better functional outcome. So in this tumour here in the left upper lobe, this is removed en bloc together with the section of the left main bronchus. And this is removed, and then you have an anastomosis. So you have an anastomosis between the left main bronchus and the left lower lobe bronchus. And obviously, if you have an anastomosis, you have a higher rate of complications, and we see a higher rate of complications with a sleeve. Now, this anastomosis is usually reinforced with some sort of vascularized tissue, such as omentum or intercostal muscle, to try and reduce the risk of dehiscence. The most common site for sleeve is the right upper lobe, and that's because the bronchus intermedius is longer, so the anastomosis is relatively easier to perform. And as I said, when you're following up patients with sleeve, you'll find it difficult to tell that they've actually had a sleeve versus a standard lobectomy, except the complication rate is higher, and this patient unfortunately developed a bronchial pleural fistula post-sleeve. So as lesions get more central and where sleeve is not possible, then you move into doing a pneumonectomy. Pneumonectomy can also be done for multifocal lesions. However, we often combine doing lobectomy with some type of ablative treatment in patients to try and avoid doing a pneumonectomy. But in these more central tumors, you remove the entire lung together with reinforcing the bronchial stump with vascularized tissue, and the entire lung and pleura are removed. In terms of following these patients up, very standard. You see the pneumonectomy cavity filled with air with a drain in situ, and this then over time fills with fluid. And fluid usually should be up to the top by about day 14. Volume loss is quite variable. Some patients you get a lot of volume loss to the side that's been operated, as in this case, some patients you get relatively little. So it's kind of variable. More commonly you see more pronounced volume loss when the tumor has been removed from the right side, and also in younger patients because the airway is probably more compliant. In terms of following these patients up, it can be quite difficult. These are both patients without recurrence, and this patient has thickening of the residual parietal pleura, which is common finding. This patient has much more pronounced thickening. He doesn't have tumor recurrence, but probably got an infection post-operatively, which resulted in this quite nodular and diffuse thickening. And this is difficult when you're following these patients up to tell if this is actually a recurrence. Sleeve pneumonectomy is a relatively uncommonly performed procedure, and this is when you get a tumor that's even more central. So we thought this patient would be suitable for standard pneumonectomy, but when they had an endobronchial ultrasound, the tumor actually extended all the way to the carina. So in this case, the carina needs to be removed. So you remove the lung, carina, and then you anastomose the left main bronchus to the trachea. There's quite significant complications associated in morbidity with this procedure, but it does, if technically successful, results in a good functional outcome for these patients. So if I move on just from talking about the surgical operations and to talk about complications, and what I'd like to focus on are really ones that we identify as radiologists rather than the ones that thoracic surgeons come down and tell us that we've missed on a chest x-ray. So I'll talk about a few interesting early and then some late complications. So the first patient is a 72-year-old man who had a right lower lobe lobectomy for an adenocarcinoma. And had a sleeve done and everything looked fine, but on day 4 developed, and I've seen this radiographed a few minutes ago, patient developed extensive pleural air, and what's obviously happened in this case is that the bronchial anastomosis is broken down and you've now developed bronchial pleural fistula. And when patients develop bronchial pleural fistula, the accumulation of air is usually relatively rapid. Patients become quite unwell quite quickly because the air it becomes very uncomfortable without a drain, and certainly in situ. If they have a drain in, you'll notice massive output from the drain increasing. Thankfully, the incidence is declining due to better surgical technique. When patients develop bronchial pleural fistula in the first week, that's usually due to poor surgical technique. If they occur later, after a week, it's usually due to infection. However, some patients can develop bronchial pleural fistula years later, and in my experience, that's often due to tumor recurrence, although there can be coexistent infection with it. A similar appearance, and I'm sure everyone is familiar with this, in a patient who've had a pneumonectomy, we see the fluid level begin to rise on day 3, but on day 5 it drops. And the reason it's dropped is because they've developed a bronchial pleural fistula, which we attempted to drain with a tube, which wasn't successful. We used a very small tube, and the patient went on to have surgical reintervention. So small bronchial pleural fistulas can resolve spontaneously with tube drainage. Larger bronchial pleural fistulas usually require repeat intervention, and that's usually reinforcing the anastomosis or wherever is broken down with vascularized tissue, so omentum or intercostal muscle, to try and close off that hole. And patients do respond quite well to it and get a good outcome if it can be treated effectively. Just this case, I suppose, is a close cousin of bronchial pleural fistula, but less pronounced. So this patient on day 1, everything was going well, drain in situ. Day 3 developed a bit more surgical emphysema than he had before, and I hope it projects, but I added this in case it didn't. But on day 4, developed a small pneumothorax. And what this is a prolonged air leak. So this is a relatively small amount of accumulation of air as opposed to a bronchial pleural fistula where it's very rapid. And these patients, probably in patients who have bad emphysema and either they get a small air leak or they may have had a tear at the time of surgery and they're getting some sort of contraflow of air that results in this small pneumothorax. Usually responds well to tube drainage. Some patients may require pleurodesis and it may result in a prolonged hospital stay, but rarely requires any surgical intervention. You do, if you follow up patients immediately with CT after they've had thoracic surgery, you'll often see air around bronchial stumps. We're often asked to do CTPAs, as I'm sure everybody is in these patients when they get a little bit shortness of breath. And this air is probably within normal limits. You see it probably it may be a small contained leak. It may just be from the operation if it's occurred immediately, but it's usually of no significance if it's contained around the bronchus. So moving on, this is a 69-year-old patient with a right upper lobe squamous cell carcinoma who was day 3 post-lobectomy, and you can see there's multiple fluid levels. Now, often the lung on the side that's been operated looks dreadful, and the surgeons rarely get that stressed about it. It's when they get changes on the contralateral side, it starts to worry them. But this patient by day 8 had become quite unwell and septic. And you can see there's costal pleural extension of the effusion, and the patient had a CT which showed split pleural enhancement. This patient has developed an empyema. And empyemas, when they occur, they're often associated with bronchial pleural fistulas. If they're not, it's probably due to surgical contamination at the time of the operation, something our surgeons love us suggesting. And the majority of empyemas can be treated with tube drainage and antibiotics. Occasionally, patients require surgical intervention. And this is an Illusor flap. We've probably done 2 of these over the last several years in our institution. And this is where you actually form a flap into the chest. So you remove a few ribs, and then you do a U-shaped flap which is rotated into the chest cavity to sterilize it. But you can see very significant morbidity associated with this and a very debilitating operation if it's required. So this is a case of a patient who had a pneumonectomy. You can see on day 3 the pleural space is beginning to rise, everything looks good, but he developed some chest pain, and I think what you'll notice here is the trachea is quite significantly deviated to the contralateral side, which is unusual. We initially thought maybe the space was infected, but when we did an aspirate, we got chyle out. And this patient has a chylothorax from a thoracic duct injury, which we went on and actually embolized, not successfully, unfortunately. We're occasionally asked to embolize the thoracic duct in cases like this. More common to see chyle leaks in patients who've had esophageal rather than pure thoracic surgery, but we do see it. And that contralateral shift of the trachea is a good tell for this. You don't see this generally from other causes. So just a few, 2 complications from post-operatively that occur in the later phase. So this is a 60-year-old man who was 3 years post-pneumonectomy and had been doing quite well, but came into the hospital obtunded. And we did a CT, and the patient unfortunately has developed a bronchial pleural fistula after his pneumonectomy, and the cavity is filled with air. And we were convinced this patient probably had recurrence, and we eventually proved it with endobronchial ultrasound. But unfortunately, this space got infected, and the patient developed a bronchopleural cutaneous fistula, which is an extremely difficult abnormality to treat. But late bronchial pleural fistulas, you should be concerned that the patient may have tumor recurrence. So the final case, before moving on to talk about recurrence, is a patient with progressive shortness of breath 4 years post-pneumonectomy. And you can see there's very significant mediastinal shift to the side that's been operated on. And we did a CT in this patient. The left main bronchus there has been pinched by the left pulmonary artery and the aorta between the 2 of them. And this patient has developed a post-pneumonectomy syndrome where you get recurrent infection, progressive shortness of breath, and eventually, because of the pinching of the airway here, patients can develop tracheomalacia and bronchomalacia. So when this is detected, and it's something to suggest early if you see progressive mediastinal shift, is to remedialize the chest. So breast implants are usually inserted into the chest in this case, and the patient had a very good functional outcome and improved significantly after the chest was put back in place or remedialized. So quite effective treatment if you can identify it. Okay, so for the rest of the talk, I'm going to discuss recurrence. And we know that recurrence for patients who've had lung cancer surgery is common. Certainly over 50% of patients will recur, probably about 50 to 60% overall will recur. Recurrence is less common in those who present with earlier stage disease, and they tend to recur later. Patients with more advanced disease who had surgery tend to recur earlier, and they're more likely to recur. And recurrence rates in stage 3 disease can be upwards of 80%. Just an interesting paper from a Japanese group which looked at recurrence or risk factors for recurrence. And tumours over 3 centimetres are more likely to recur than smaller tumours, and they tend to recur earlier. Likewise, with nodal disease, you're more likely to recur earlier if you have more advanced disease, and you're more likely to recur overall. And if you look at the hazard ratio for recurrence in these cases, so if you've N0 disease, in green you have local recurrence, and in red you have distant recurrence, it's about equivalent in terms of local to distant recurrence. However, if you've more advanced disease, you're much more likely to recur distantly. And likewise, patients with N2 disease, much more likely to recur distantly than locally. And local recurrence is really what you want to try and identify, because these patients can be treated with salvage treatment, which can be curative in some cases. Usually occurs before 3 years, and generally underreported, it's not spotted. Local salvage treatment are available, and you can result in a significant survival advantage. Obviously, new primary lung cancers is also a consideration. I'll talk about that at the end. So where do patients recur? Well, this is a nice paper published from Valerie Ruch's group in Memorial Sloan Kettering, and they looked at 1,300 of their patients with early stage disease who recurred. Now, their recurrence rate is low, it's 20%, which is quite low. And they found about a quarter of the patients recurred locally, about almost 50% were distant recurrence, and then the rest were a combination of local and distant. And if you look at the local recurrence, nodes are the most common, then parenchymal recurrence, and finally a staple line recurrence is the least common. And interestingly, our hospital patients have their surveillance done in peripheral institutions and are referred back to us to assess. And in my experience, staple line recurrence is the most common site that people who aren't experienced with following up lung cancer call recurrence. And I'll discuss that in more detail in a few minutes. In terms of distant recurrence, the most common site was pleura, but pleura is not necessarily metastatic. Some pleural recurrences can be treated with curative intent. Then lesions in the other lung, and then brain, liver, and bone, I suppose the truly metastatic disease. When you're looking for trying to identify recurrence, it's very important to know what type of operations patients have done. So this is a patient referred to us a couple of weeks ago at our MDT who was 2 years post-operatively, and it was reported that they suspected the patient had recurrence in the lung apex. Now, they didn't have the baseline imaging, and actually he'd had soft tissue thickening quite significant in the lung apex all along. And the patient actually originally had a Pancoast tumor with neoadjuvant downstaging. So thickening in the apex is expected in these patients post-operatively. You also need to know where to look, where are the most common sites for recurrence. So if we look through the most common sites, well, certainly nodes within the thorax are the most common. So it's important to carefully scrutinize your nodal stations. It's important you usually, if you've had a mediastinal lymph node dissection, they tend to recur outside of where the dissection has occurred. Not always, but this patient had a right lower lobe tumor, and they wouldn't have removed the station 2-OR nodes. This patient got a recurrence in 2-OR. When you're looking at your mediastinal nodes, also do carefully assess the supraclavicular fossa. This patient also had a supraclavicular lymph node recurrence, which would make them unsuitable for salvage stereo for this lesion. But also it's an easier place for us to get a tissue biopsy, so we did an FNA to confirm recurrence rather than the patient having to have an endobronchial ultrasound. So it is important to look for those nodal stations to find a site where you may find it easy to get tissue. New nodules are relatively easy to detect. MIP imaging is obviously helpful. If it's an isolated abnormality, we will usually define this as a new primary lung cancer and try and treat it aggressively. Now, recurrence at the stump, it's the least common site of local recurrence, but it's, as I said, is the one we're asked most frequently. So I hope this projects okay, but this patient had a very significant chest wall resection, and adjacent to the bronchial stump, we see pleural thickening, or we see soft tissue thickening. And this is probably fibrosis around where the sutures are, and this is not recurrence. We see this all the time. Likewise, this is a patient who had a sublobar resection, and there was nodular thickening along the resection, which was thought to be recurrence. We did a PET-CT on the patient, and the original tumour was PET-avid, and this was non-PET-avid, and on follow-up this has been stable all along. So particularly with the segmental resections, you do see thickening, and it can be quite nodular along the suture line, which extends back to the hilum. When you see recurrence at the bronchial stump, it's usually quite obvious. Now that may mean you've missed it on a previous CT, but when you see it, it's usually relatively obvious. So this patient had recurrence at a right upper lobe sleeve resection, and had positive margins, so had radiotherapy. So high risk, a high chance of having recurrence. And you can see the recurrence here adjacent, so very significant soft tissue thickening, and we confirmed this on PET-CT. But because she's had a recurrence, it doesn't mean that she's not suitable for curative treatment. So curative options here would be to do a pneumonectomy in the patient. Unfortunately, she wasn't suitable for that. And we couldn't also radiate that because she'd had previous radiotherapy because of her positive margin. So what I did was I did a microwave ablation of the lesion, and we have had a very good response to this, and on 2 years follow-up, we've had no recurrence. So there are salvage options available for these patients, so it's important to identify the recurrence as soon as possible. So I suppose twinned with the bronchial stump is the pulmonary artery. And you often see soft tissue thickening adjacent to the pulmonary artery where it's been transected. And you can see in this case over 3 years, this all was very stable, but on year 4, we saw a new soft tissue thickening here. We were concerned this was recurrence, and we were asked, we were going to try and confirm it. So endobronchial ultrasound was performed, and the endoscopist actually said they think this is thrombus because it looks like it's in the pulmonary artery. And we anticoagulated the patient, and on follow-up, this regressed. So the development of thrombus within the pulmonary stump is not uncommon. It can really occur at variable stages post-operatively, so it's just important to be aware of it. This is a more florid example of that. This is a patient who had a right upper lobe resection, and on the 6-month CT, we saw soft tissue thickening adjacent to the pulmonary artery. This got worse 3 months later, got even worse 3 months later. And we were fairly convinced this was tumour recurrence. Endobronchial ultrasound demonstrated no tumour. So our thoracic surgeons obviously asked us, could we do a percutaneous biopsy of this, which I was a little bit reluctant to because of the vessels. And it got worse. So we did a PET, and the PET was non-avid. So we were fairly convinced this was thrombus. We did an MRI to confirm this, and the MRI shows no enhancement within this area. And this is thrombus developing within a very abnormal pulmonary artery stump. And you do see this over time. It's important to follow this. Don't leap to the conclusion that this is recurrence. You may need PET to help, but it's certainly not always tumour recurrence around the pulmonary artery. Pleural recurrence is the most common site of what is classified as distant recurrence, but as I said, not all cases of pleural recurrence are necessarily not treatable. Now, it's very obvious when it's a case like this, a very nodular pleural thickening, very concerning for disease recurrence. It's more subtle in this case. So this patient had a right middle lobectomy, or the middle lobectomy even, for a tumour which was squamous cell carcinoma. And on the follow-up CT at a year, there was a bit of pleural thickening, but I was fairly convinced this was within normal limits. But the patient developed chest pain 6 months later, and you can see has had a very extensive pleural recurrence at this time. And when I went back to look at the CT following it out, yes, there was quite significant pleural thickening, maybe on a coronal reformat, that there's loss of definition here of the intercostal muscles, but I think that's very difficult to call. But do be careful if you see pleural thickening. As I said, it can be a normal finding, but it can be tumour recurrence. In some of these cases, you may require PET to further evaluate. So final pleural recurrence, it's not truly a pleural recurrence, if you could excuse the pun, is close to my heart, and you'll see why in a second. So this was a tumour that was resected, which we thought was a T2A squamous cell carcinoma from the lingula, from the left upper lobe. And on a 1-year CT, everything looked good. But at 2 years, we saw this new area of thick soft tissue thickening in the anterior mediastinum. This is an unusual site to get recurrence. But when we went back to the original surgery, actually it turned out it was a T3 tumour with pericardial invasion. So this would then, in that case, not be that unexpected. and we did a PET-CT to confirm its recurrence. I'm sure, I don't know what your thoracic surgeons are, but our thoracic surgeons always ask for tissue confirmation because they're convinced that nothing they do ever recurs. So we were asked to do a biopsy of this lesion, and you can see the left ventricle sitting behind it. So we did an ultrasound and CT-guided FNA and confirmed recurrence. And the patient then had this resected and has had stereotactic radiotherapy subsequently and has done actually very well. So some of these lesions are suitable for salvage treatment. One thing to say is when patients have had an extensive chest wall resection, as in this case, with a number of ribs removed, assessment of recurrence is a little bit of a mug's game because it's very difficult on CT to assess. You get a lot of pleural thickening and you may require PET in these patients. In terms of the contralateral lung for recurrence, it's very easy in a case like this. The patient had left-sided surgery and has obviously had extensive right-sided recurrence. But in these cases, obviously, it's more difficult because you have an isolated abnormality in a patient who's had pneumonectomy. And we will usually treat these, if we don't see any evidence of metastatic disease, we'll usually call these a new primary lung cancer. And we know that the incidence of new primary cancers is about 2% per year. The population is probably at higher risk than those that are in the lung cancer screening trials, so we certainly should be following up these patients to find new primaries. They often present as relatively early stage disease and they're suitable for curative treatment. So it is important to follow them up. So if we then just discuss the surveillance strategy for the patients. I was asked this question in the 1990s. Well, I was in school for part of it, so I probably wouldn't have given a very good answer. But CT versus chest X-ray, which should we choose? There wasn't much evidence in the literature to say CT had any advantage. But certainly from the mid-2000s and 2010 onwards, we're starting to see good evidence that lung cancer, or surveillance of these patients, there is a survival benefit, not only from identifying new primaries, but also from identifying areas of recurrence. And I think the salvage options we have are much more significant than we had probably in the 2000s. So I think this survival advantage for CT is only going to get stronger. There are obviously negatives associated with this. 60 to 70% of patients with recurrence have metastatic disease, and at present there is limited evidence for treatment of asymptomatic metastasis. Now this may change in time. There's also cost and additional procedures associated with CT surveillance, and there's very significant patient anxiety as being part of a CT surveillance program. Various organizations have various follow-up guidelines. Some recommend it. The majority now will recommend CT for follow-up. Some don't. Our institution, we do a CT at 6 months and then at a year, and then we follow up every year for 5 years. And we may be extending that out further towards 10 years to identify the new primary lung cancers. How good are we at surveillance? The evidence is limited. This is a paper published in the mid-2000s. And was actually interesting thoracic surgeons assessing for recurrence, and they said that their their negative predictive value for CT was 99%. It's certainly not that high. Positive predictive value is pretty low. You will identify lots of things that aren't tumor recurrence that you will be required to evaluate further. So we don't really know how good we are as yet. PET-CT is probably better. But the evidence is, and we use PET-CT for following up patients who've had stereo and for ablation, but we don't use it for lung cancer surgery. But that may change in time. How good are patients at surveillance? And I think that's a really important question. A very good paper published last year from MD Anderson, and they looked at their cohort of patients who'd had lung cancer surgery and how good were they at follow-up. 2/3 of the patients did not undergo the recommended surveillance regime. So patients are really not very good at following up. Interestingly, tumor size, being married, I don't know whether that's from nagging, or living less than 100 miles from the medical centre were associated with an increased number of imaging studies and greater adherence to the guidelines. Interesting. So to summarise, it's important to know the different types of surgery patients have, both to identify complications, but also so that you can identify local recurrence where you may actually be able to perform salvage treatment. And finally, I think you should be performing CT for surveillance of patients who've had lung cancer surgery. Thank you very much for your attention.